Welcome back to Rebelcast. I'm your host, Salim Razai, and this is episode 124, Nitrates in Right-Sided Myocardial Infarctions. Now, the background on this is that, nitrates can help improve symptoms and maybe ischemia in the setting of acute myocardial infarction. That's why we use the medication. Current teaching, though, holds that nitrates should be avoided in patients with potential right ventricular myocardial infarction due to the risk of decreasing preload and maybe precipitating hypotension. Now, this belief is based on a single 1989 study of 40 patients with right ventricular myocardial infarction. And because of this study, this recommendation is endorsed by the American Heart Association and the European Society of Cardiology guidelines. Now, to help me talk about that study and a new study that just came out is my partner in crime, the buttery smooth, the Swami. What's up, man?
Hey, man, good to be back. Great topic to dive into. It is one of these dogmatic teachings that if you actually ask people, why do we do this? They're like, because I said so, because someone told me. And nobody has really actually gone back and looked at the literature. But Salim, you and I actually pulled that 1989 article and we dove into it. We were 12 at the time when this study came out. So it is not surprising that we didn't really know much about it.
And what did that study show anyway, Swami? Can you just tell the listeners a little bit about it?
Yeah. So like you said, they had 40 patients that they took. They put them into groups getting the nitrates, not getting the nitrates, and they looked and saw, what do we see? And they saw that there was more hypotension in the group that got nitrates when they had an RV infarction. But there were so many issues with this study. It's not a randomized trial. We don't know how the patients were actually selected. There's a lot of just issues in the methodology. And it's fine. In 1989, if this was the best data that we had to drive forward our recommendations, that's okay. The question, though, is do we have better data over the intervening 35 years that should better advise what we do?
And we do. We have a paper now, Wilkinson-Stokes et al., Adverse Events from Nitrate Administration During Right Ventricular Myocardial Infarction, a Systematic Review and Meta-Analysis, published in Emergency Medicine Journal 2023. The clinical question the authors were trying to answer is giving nitrates to patients with right ventricular myocardial infarction associated with increased adverse events compared with nitrate administration to patients with myocardial infarctions in other regions of the heart?
This is a really good question to ask, Salim, and it's really interesting because, we said, there's this 1989 paper that the recommendations are based off of. This is a systematic review and meta-analysis. That tells us already there are a bunch of other articles that have come out since. It sounds like they've been relatively ignored by the groups that create guidelines because we don't see additional citations. Even if all of the papers that were included in this systematic review and meta-analysis say, no, you shouldn't give nitrates, you would think that there would be some updates in the guidelines showing that there's more robust evidence for that recommendation. We don't see that. So it's really important for us to look at this article. The other piece of this, and we're going to get to it more in the discussion, is that we do have data telling us that nitrates are good for patients with myocardial ischemia, myocardial infarction. And so we should think about, can I give these in these circumstances if they're safe? So what this group did, again, is a systematic review, meta-analysis. The exposure of interest was administration of nitrates via any route and any dose.
And their primary outcome was all forms of adverse events reported in the included studies. And those included things like hypotension, bradycardia, worsening altered mental status, syncope, and cardiac arrest.
Right. So interestingly, this is really a safety study. Is this safe to do? And a lot of that is predicated on the author's understanding that there is data telling us that it is beneficial. So we're not looking for benefit here. We're just looking for safety. They included studies that looked at acute myocardial infarction and specifically looked at patients with RVMI. It was only looking at studies published in English. And really the only groups of patients they excluded were those where coronary vasospasm was the underlying etiology.
And they included 5 studies in their analysis, Swami, but only 2 of them were observational studies using sublingual nitroglycerin 400 micrograms. And that's what they used for their meta-analysis. What did that meta-analysis show?
So as far as adverse events, it showed that the group that had RV myocardial infarction had about a 17% rate of the bad outcome, which is hypotension, bradycardia, altered mental status, or syncope. In all of the other MIs, the rate was about 9%. Now that sounds like a pretty significant difference, 17% versus 9%, but the relative risk here was 1.31 with a confidence interval crossing 0. So this is a non-statistically significant difference. And no patients had cardiac arrest or death. So even when we look at those adverse events, they're not the real bad ones, Salim. They're not the ones that really make us worried about things. They're not those things like cardiac collapse and death. So that's what we really care about. We didn't see that here.
Exactly. And as far as the strengths, I mean, I think this is a clinically important question because it's potentially game-changing in terms of how we manage these patients. They searched a ton of databases. They included all the studies that they could find, and they did a quality assessment using standard appraisal tools. And if there was data missing, they actually contacted the corresponding authors to get that missing information. But Swami, there were some pretty big limitations of this meta-analysis and systematic review.
Yeah, what we would like to see is a bunch of RCTs that are brought together into a systematic review and meta-analysis, and we don't have that. None of the included studies were randomized controlled trials. All the study samples were combined inferior and right ventricular myocardial infarction, so we don't know how nitrates would act on isolated RVMI. That's okay, because I think most of the patients that have RVMI also have inferior wall MI, but not all of them, and that's really what we're looking at. So yes, there are some limitations here. It's the best evidence we have. When we have this kind of data that we're basing recommendations off of, what it really yells for is, hey, we're showing that there's no risk in the limited data we have. Let's do a randomized controlled trial. Now, whether that'll ever happen, there's no real money in this. I'm not sure that there's any interest, but it would be great to use this to say, well, we have a good reason now to do a randomized control trial.
Yeah, 100%. And, to be fair and to be balanced here, this review provides low certainty evidence that there's no statistical significant difference in the rate of adverse events when nitrates are administered to patients with the right ventricular myocardial infarction compared to other regions of MIs. Now, Swami, I'm going to tell you that hypotension was the primary adverse outcome that was reported in this study. And the good news is nitrates have a very short serum half-life of about 1 to 4 minutes. And so it's most likely that hypotension is going to be transient in nature. And I don't know, transient hypotension doesn't really seem as clinically meaningful as, like you said, somebody arresting or having symptomatic bradycardia. They just didn't see that difference, but it was very limited with the evidence that they had. Now, Swami, we did a review back in, I got to pull this up because it's been a while. We did the death.
Yeah, this was back in 2017.
2017, 7 years ago, called The Death of Mona in Acute Coronary Syndrome. And it's part 3 where we looked at nitroglycerin and nitrates. Now, there was a 2009 Cochrane review that we looked over. And what did that Cochrane review show?
Yeah, so that Cochrane review showed that there was a benefit to nitrates. And this is important, Salim, because giving us safety and saying this is okay to do doesn't mean we should do it. We have to know, does the intervention actually benefit the patient? So in this 2009 Cochrane review, they looked at mortality after the use of nitrates in patients with myocardial infarction. And what they found was that at 2 days and 10 days, there was a statistically significant reduction in mortality in groups that got nitrates. Now, if you go out to 30 days, there was no difference. That's not surprising to us. That short term is what we expect to see from a drug like this. But I think that really advises what we do. So not only do we want to know if it's safe, we want to apply this to our patients if it is safe. So it is really asking that question, not can I do it, but should I do it? And based on that 2009 Cochrane review, we should be doing it as long as it's safe. The nice thing is, like you said, this hypotension is going to be transient. We can give them a little bit of fluid. The medication is going to wear off. And that advises me in 2 different ways. First is don't use nitro-paste. And in that old study from 1989, some of those patients got nitro-paste. And the reason I'm saying not to use that is because it's a little bit more difficult to take away nitro-paste from the patient if something happens. It's pretty easy if you're using IV nitroglycerin. Even with sublingual, you can't take it away, but it goes away really quickly. It gets absorbed, it's done. The transdermal paste can kind of hang around for a while. So I would not use transdermal. I would use sublingual. I would use IV instead. And the other thing this tells us is if you did do it, it's not the end of the world. And if you did get a little bit of hypotension, it's okay. You're not going to see cardiovascular collapse. You're not going to see a cardiac arrest.
And the way I would apply this, I guess, clinically, like taking all that evidence we just discussed, is if I have a patient who comes in, they're having a right ventricular MI with or without inferior component to it. If they're kind of a soft blood pressure or they're hypotensive, I'm probably going to not use nitrates. If they come in and they have a normal blood pressure, why not give them just a little test dose? I mean, if hypotension is the biggest thing we're going to cause, and we know that that's a quick on, quick off, then I'm willing to give it a shot. And that's kind of the way I took this evidence in addition to some of the older evidence. I don't know if you're doing something different, but that's kind of the way I took this.
No, I think that's exactly it. If the patient's blood pressure is soft, I'm going to hold off. I think that's the right thing to do. If they're normotensive, I'm probably going to give them sublingual nitroglycerin to relieve their symptoms. And then of course, we're going to be closely monitoring them, and they should be going to the cath lab or getting thrombolytics based on your institution. I think really what this tells us is you can do it, but we should also really be focused on the important things in MI, which is revascularization.
So what did the authors conclude in this study, Swami?
So they concluded that this review suggests the AHA and ESC contraindications are not supported by evidence. Key limitations include all studies having concomitant inferior and RVMI, not evaluating beneficial effects, and very low certainty of evidence. As adverse events are transient and easily managed, nitrates are a reasonable treatment modality to consider during RVMI on current evidence.
And I think our clinical take-home point is, from a clinical perspective, the potential benefit of analgesia, reduced sympathetic stimulation, and a short-term mortality benefit in the setting of RVMI seems to outweigh the potential of transient hypotension with the use of nitrates. Now, as we said at the beginning, better studies are needed, but this systematic review and meta-analysis argues against a contraindication against nitrates in the setting of RVMI, and maybe one of precaution.
Salim, I love doing some myth busting. It's great to look at this one. And again, I don't think we pay a lot of attention to nitrates in MI. We think about it in these RV infarcts, and we should think about it in these RV infarcts, but it's probably okay. If you think it is clinically indicated to give the patient a nitrate to relieve some of that ischemia, it's probably okay to do it.
And there you have it, Rebel EM listeners. Let us know your thoughts, comments, and questions. And until next time.